Hi, it's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode I answered another question from one of our readers, and the question last week was part 5 of my 84-year-old dad has been in intensive care for 3 months. He's ventilated with a tracheostomy. The doctors want to let him die and turn off the ventilator. We want to take him home instead. What are our options? You can check out the answer to last week's question by clicking on the link below this video. In this week's episode of Your Questions Answered, I want to answer another question that we get quite frequently from our readers. And the question this week is, what's the difference between an induced coma and sedation? In today's question, I want to explain what seems to be very confusing for many families of critically ill patients in intensive care. Many families who come to seek out our expertise and advice seem to get confused about some of the terminology being used. So today I want to look at some of the terminology, and I want to make sure that by the end of this video you and your family understand the difference between an induced coma and sedation. Let's start with an induced coma. An induced coma is a medically induced coma where critically ill patients are put asleep by powerful sedatives, and most commonly used sedatives are propofol or diprivan or midazolam, also known as Versed, and also being used are strong painkillers or opiates such as fentanyl, morphine, and in some rare cases remifentanil. And that's being done in order to be able to tolerate mechanical ventilation and a breathing tube. So you may ask which issues are leading to what treatment, and it's obviously a chicken and egg question. Is the induced coma leading to mechanical ventilation and the breathing tube, or vice versa? The answer is really that it depends, and in some instances a critical illness such as a severe pneumonia, asthma, rib fractures or COPD are leading to the inability to breathe. Therefore it requires mechanical ventilation and a breathing tube as a first line, and also as a life-saving and life-sustaining treatment. Mechanical ventilation with a breathing tube can't be tolerated without sedation and painkillers or opiates, and therefore some critical illnesses warrant intubation. Intubation is also known as the insertion of a breathing tube in the throat. And that is followed by mechanical ventilation, and it's basically a life-saving measure first. Now, before a doctor can intubate, again, intubation is the insertion of a breathing tube. A critically ill patient, they need to be induced into a coma, because again, intubation, the breathing tube and mechanical ventilation can't be tolerated without an induced coma, as it's way too uncomfortable. The reason mechanical ventilation and the breathing tube are so uncomfortable is simply that it requires high pressures to ventilate a critically ill patient, and having a breathing tube stuck in your throat is very uncomfortable too. In other circumstances, an induced coma comes before the breathing tube and the mechanical ventilation. For example, in severe or after severe road traffic accidents followed by multi-trauma, where severe fractures have been sustained and severe pain or major blood loss can be expected, an induced coma is used to then instigate mechanical ventilation and the breathing tube, and it's another indicator for an induced coma. In those circumstances, it's not necessarily a breathing problem that's leading to an induced coma and to mechanical ventilation, and it's more of an assessment of an overall critical or catastrophic clinical situation where complications are to be expected and therefore mechanical ventilation, a breathing tube and the induced coma are life-saving measures to treat a critical illness. Especially in such complex clinical situations like polytrauma, sepsis, cardiac arrest, etc., an induced coma, a breathing tube and mechanical ventilation are treatments of choice. An induced coma is also a procedure being used during anesthesia for surgery. So I have also written an article and made a video about what is an induced coma and why is my critically ill loved one in induced coma. So you get all the details there. So let's move on and let's now look at what exactly is sedation being used for. So sedation, on the other hand, is just referring to the drugs that are being used for an induced coma. Strictly speaking, sedation or sedatives are drugs being used to put a patient asleep. Again, the most commonly used drugs to put a patient asleep or in an induced coma are propofol, also known as Diprivan, and midazolam, also known as Versed or Domicum. Propofol is a short-acting sedative, and it means that even after high doses of propofol, a patient should wake up within minutes or hours because it gets metabolized really quickly. Propofol is also commonly being used for short-term induced coma, and it can also be used for longer-term induced comas. Its main side effect is hypotension, also known as low blood pressure. Midazolam, also known as Versed, is a sedative that's also being used to put patients asleep and in an induced coma. It's more longer acting and it's often being used for longer term induced comas. Midazolam or Versed is also a benzodiazepine and can be addictive in nature. Therefore, if critically ill patients in a long-term induced coma are coming out of the induced coma, it's recommended to reduce midazolam slowly, because critically ill patients might be addicted to it and they need to come off slowly due to potential withdrawal. The main side effect of midazolam or Versed, therefore, is addiction and potential withdrawal after use. What's also important to note is that sedation and sedatives can't be looked at in isolation without mentioning and looking at opiate drugs. Again, opiate drugs are strong painkillers. There is usually no use of sedation and sedative drugs without the use of opiate drugs such as morphine or fentanyl. The induction of a coma always requires both sedation and strong painkillers or opiates. The reason being is that sedation will put a patient asleep but can still cause pain if not well managed. Hence, you can put a patient asleep with sedatives like propofol and midazolam, get them on a ventilator and insert a breathing tube, but that could still cause pain with the use of opiates such as morphine or fentanyl. It's also important to note that many critically ill patients in intensive care who receive high doses of midazolam as well as receive high doses of opiates like morphine or fentanyl, especially after a prolonged induced coma, are at risk of withdrawal from those powerful medications. Both midazolam as well as morphine or fentanyl are addictive drugs, and therefore coming off those drugs often needs management and monitoring so that patients don't go through a withdrawal that's not being properly managed. Unmanaged withdrawal from midazolam as well as opiates like fentanyl or morphine can cause critically ill patients to become confused, agitated, delirious, or even aggressive. It could potentially also cause seizures. I really hope this clarifies and you now understand the difference between an induced coma and sedation. You can also check out the following articles and videos for more information about induced comas. So I've done articles and videos about how long does it take to wake up after an induced coma. Also, how long can someone stay in an induced coma? Also, how long can you keep a critically ill patient in intensive care in an induced coma? And the 10 answers to the 10 most frequently asked questions when your loved one isn't waking up after an induced coma. You can find the links to those articles and videos below this video in the written version of this blog. So, how can you become the best advocate for your critically ill loved one? Make informed decisions, get peace of mind, control power and influence quickly whilst your loved one is critically ill in intensive care. You get to that all-important feeling of making informed decisions, get peace of mind, control power and influence when you download your free instant impact report now by entering your email below. In your free instant impact report, you learn quickly how to make informed decisions, get peace of mind, real power and real control, and how you can influence decision making fast whilst your loved one is critically ill in intensive care. Your free instant impact report gives you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free instant impact report now by entering your email below. In your free instant impact report, you learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions, discover the many competing interests in intensive care, and how your critically ill loved one's treatment may depend on those competing interests. How to eliminate fear, frustration, stress, struggle and vulnerability even if your loved one is dying. You get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power and influence in your situation. You'll get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You'll get crucial behind-the-scenes insight so that you know and understand what's really happening in intensive care, and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you also check out our blog section for more tips and strategies, or simply send me an email to support@intensivecarehotline.com with your questions. Or you can call me, find international phone numbers on our contacts tab. Also check out our ebook section where you get more ebooks, videos and audio recordings, and where you can also get one-on-one counselling and consulting with me via Skype, over the phone or via email by clicking on the products tab. This is Patrick Hutzel from intensivecarehotline.com, and I'll see you again next week in another update.